evening, and welcome to Chesapeake Public Schools Family Empowerment Webinar presented by the Office of Family and Community Engagement, or FACE. I am Lisa Carey, one of the FACE specialists. Our office, which is under the Department of Engagement, seeks to create meaningful partnerships in order to inspire, engage, and empower families, educators, and community agencies to support the initiatives of Chesapeake Public Schools. We are typically available Monday through Friday from 8 a.m. until 4 p.m. and can be reached by our main phone line at 757-482-5923 or face@cpschools.com. We are excited to offer our families a course catalog entitled Peak Parent University that outlines all of our events for the school year. You can also catch up on pre-recorded webinars, access a wealth of educational resources, and make community connections to promote your family's well-being. Please visit www.cpschools.com and search for Peak Parent University. Thank you for joining us tonight to discuss the mental health crisis. Where are we and what can we do? This is part two of a three-part series. As you may be aware, part one focused on addiction and the opioid crisis. This webinar was recorded and can be found on our Chesapeake Public Schools YouTube channel. Please note that this webinar is also being recorded to add to the video series. Participants' cameras and the chat feature are disabled. If you have any questions, please use the Q&A feature located at the bottom of this screen. We will answer all questions at the conclusion of tonight's presentation. We have two expert panelists that will share information with us tonight, Dr. Pat King and Mr. Ed Gonzalez. Before I formally introduce our first panelist, I want to thank the City of Chesapeake, Chesapeake Integrated Behavioral Health, Chesapeake Public Schools, and the Women's Division of Hampton Roads Chamber of Commerce for their vision and support with this health series. According to KFF, an independent analyst for the U.S. Census Bureau, mental health conditions have been exacerbated since the COVID-19 pandemic, with approximately 4 out of 10 adults reporting anxiety or depression as early as 2021. In fact, from February 1st to February 13th of 2023, 32% of adults in Virginia reported symptoms of anxiety and or depressive disorder, compared to 32.3% of adults in the United States. This study is one of the many reasons why we all have collaborated to ensure we can provide our families with information and resources for Chesapeake Public Schools to thrive. Our first panelist this evening is Dr. Pat King. She is a psychiatrist in Chesapeake, Virginia. She received her medical degree from Meharry Medical College School of Medicine and has been in practice for over 20 years. Dr. King has expertise in treating anxiety disorders, bipolar disorder, depression, among other conditions. She has served in a variety of both professional and community capacities, one of which being a member of Delta Sigma Theta sorority, which is a national service sorority whose projects revolve around a 5-point thrust, one of which is physical and mental health. At this time, I will turn the program over to Dr. King. Welcome, Dr. King.
Good evening. Thank you so much for the introduction. And thank you to all of you who are spending your evening with us. Really appreciate your presence here. Today, we have an opportunity to talk about mental health. It's a topic that's near and dear to me, and one that I've spent the last 35 years of my life devoted to. I have seen a transformation in diagnosing and treating mental health conditions over the last 30 plus years, and I am enthralled by the interest and the educational opportunities that have availed themselves. We all must continue to work together to destigmatize mental illness and to free those who have been ostracized and ridiculed. It is up to us and the next generation to break down the barriers that separate those with mental illness from the rest of the world. So what is good mental health? What does it look like? Well, good mental health means you're motivated, have the mental acuity and the initiative to engage in life, to participate in sports, to participate in academics, to be functional in a workforce, to socialize with others, to eat healthy, and just to enjoy and overall engage in life and life processes. What is mental illness? I think this is really important to start with. Mental illnesses are conditions that affect how we think, how we feel, how we behave, and oftentimes they affect our mood. Some of them are occasional. Sometimes people will have one episode of a mental illness without a recurrence, but in general, mental illnesses tend to be chronic and they tend to be recurring over a person's lifespan. We know that mental illnesses can impact how people interact with each other and how people function each day. And by criteria, according to our DSM-5, our psychiatrist Bible, in order to be diagnosed with a mental illness, there must be impairment in one major area of life functioning. That might be work, it might be academics, it might be social functioning. The requirement for impairment is there to diagnose a mental illness. In the next bullet point, we know that mental illness is associated with chemical changes in the brain. And I strategically put the word associated because there's one school of thought that mental illness is caused by a chemical impairment in the brain. But there's a newer school of thought, and we're not really sure if mental illness causes brain chemical changes or if there are brain chemical changes first that precipitate a mental illness. And the research is not clear on that, but the research is ongoing. But what we do know is that mental illness is multifactorial. That means there are many components to mental illness and many factors that can contribute to the onset. And we'll talk about some of those things in some of the future slides. I often get asked about mental stress versus mental illness. So mental stress is something that all of us experience, whether it's related to problems at work, being overworked, schedules that are overwhelming. It may be due to sicknesses or losses, family problems, financial stressors, but everyone experiences some type of emotional stress in their lives. Emotional stress does not necessarily cause impairment. But if you remember, we said in order to diagnose a mental illness, there must be impairment. We also do know that if mental stress is not managed, it can lead to a mental illness. We do know that coping mechanisms can help to mitigate mental stress and mental illness, and the research substantiates this. So what are some healthy coping mechanisms? Exercise. There's more and more research that supports exercise in terms of mitigating mental health conditions and mental stress. Hobbies, yoga, other relaxation techniques, community service, helping others in your community. And also, we know the importance of social interactions and how that might help to mitigate stress levels as well. I wanted to talk a little bit about some of the commonly diagnosed mental health conditions that we actually see and diagnose. And we'll start with anxiety disorders because they are one of the most common types of mental illness that we see. And oftentimes people will say they have anxiety. That's not really specific because the DSM-5 outlines multiple different types of anxiety disorders, such as social anxiety, which is a persistent fear of social contact due to fear of being judged negatively or embarrassed or humiliated. So these people avoid social contact. Agoraphobia, that's fear or avoidance of places or situations that might cause panic or feelings of being trapped, helpless, or embarrassed. Oftentimes you hear people refer to people with agoraphobia who just remain at home because they're fearful of what may happen in the marketplace outside of the home. And then panic disorder, which describes recurrent, what we call panic attacks typically associated with rapid heartbeat, shortness of breath, sometimes numbness and tingling in the extremities. But along with that is intense fear or panic. A lot of times these patients will end up in the emergency room thinking that they're having a heart attack. And then generalized anxiety, which is anxiety about a multitude of different things, not any one thing specifically, but excessive worry and irrational fear. And then selective mutism, actually, we don't see a whole lot of that, but that's usually diagnosed in young children, can be seen in adults as well. But these are children who have a lot of anxiety, and it prevents them from being able to speak in social settings. So a lot of times it would be a child in a classroom who just does not speak in school. And then separation anxiety is excessive distress when anticipating or experiencing separation from home or a major attachment figure. And then the specific phobias are fears of specific things like fear of contamination, fear of bridges, fear of spiders or insects, fear of heights. But it's usually a specific thing that the anxiety is associated with. And then major depressive disorder is also a mental health condition that we see very commonly, causes a great deal of impairment in the lives of people who suffer from it. Today, there are about 21 million people who suffer from major depressive disorder, and it is the number one cause of impairment. And then we have bipolar disorder, which bi describes two, and it's two poles. So it's people who have high highs and low lows, but both are very extreme and can be dangerous. And bipolar disorder does also cause impairment in usually multiple areas of life functioning. Some other commonly diagnosed mental health conditions: post-traumatic stress disorder, and obsessive compulsive disorder. And I highlighted those and put those there because in the previous edition of our DSM, both post-traumatic stress disorder and obsessive compulsive disorder were classified under the anxiety disorders. But with the newer edition of the DSM, which is the DSM-5, both of these disorders were extracted from the anxiety spectrum, and they are in new categories. Post-traumatic stress disorder, commonly referred to as PTSD, refers to not necessarily personally experiencing a trauma, but it can be the result of someone who witnesses or even anticipates a type of trauma. And obsessive compulsive disorder has to do with obsessive thoughts and compulsive behaviors. We often think of people who hand wash frequently. There are so many components to both of those, but I won't get gobbled up in the details. But I did want you to know that they were previously considered to be anxiety disorders. There's a high level of anxiety associated with both. And also the treatment is the same as those disorders that we outlined under anxiety disorders. And then we have the neurodevelopmental disorders, which we do see commonly: attention deficit hyperactivity disorder. And that is the new technical terminology. You do hear people sometimes still refer to it as ADD, but technically it's ADHD. And then there are qualifiers: ADHD with hyperactivity, ADHD mostly inattentive, ADHD combined type, but the correct terminology according to DSM-5 is ADHD, whether there's hyperactivity or not. Autism spectrum disorder, ASD, learning disability, cerebral palsy, all come under neurodevelopmental disorders and are classified in our DSM-5. Also, eating disorders, bulimia, anorexia would be prototypes of eating disorders, and then schizophrenia. Why do we talk about mental health, and why do we even care? It's so important for us to know that unaddressed mental illness and poor mental health impact an individual in a very negative way. Oftentimes, these people have difficulty performing at work. They even have difficulty sometimes just attending regularly. So that increases the likelihood of job loss. increases the likelihood of financial insecurity. And also, when people are not treated and suffering from mental illnesses, they're more likely to have job-related injuries, especially if they're doing manual types of labor where injuries could be significant. And also, just errors are commonly made when people are suffering from mental illness. Of course, we know disrupted relationships with family, friends, and colleagues can be a real concern for people who are suffering from mental illness. But it doesn't just impact a person individually. There are also economic consequences related to mental illness. So employee absenteeism due to mental illness costs our U.S. economy about $48 billion a year. And of those people who are collecting Social Security disability benefits, almost 30% of them are due to mental health conditions. We know that mental health conditions significantly are associated with incarceration and homelessness cost in general. And we know that comorbidities, that means mental illnesses in combination with like substance use disorders, do contribute to crime, medical conditions, overuse of emergency facilities, and increased utilization of medical resources in general. So poor mental health does impact individuals, but it also has a tremendous impact on our economy, as you can see. So we go to the nature versus nurture when we talk about causes of mental illness. And we do know that there are two major components. And one is what we call nature, and that's your genetics. That's what you inherit from your parents. It's in your genetic pool. And then the other part is the nurture, your environment. Is your environment hostile? Is it conducive to the development of mental illness? Or is it a healthy environment that is not conducive to the development of mental illnesses? So we have done gene studies and looked at concordance rates. And the studies have shown that there are certain types of mental illnesses that do run in families and that they are linked through genetic coding. So it's not uncommon to see maybe a grandmother who suffered from depression. Maybe she has a sister who also suffers from depression, a child, and maybe even a grandchild. So we know that there is a genetic link to certain types of mental illnesses. And what's really interesting, and I always found this interesting in my training, was the monozygotic twin studies. And so they would separate identical twins at birth, and they would send one far away, and they would evaluate the development of mental illness. These studies were done a lot for schizophrenia. And it was very interesting because about 50% of the time, they would find that both twins, even separated, would come down with the same symptoms and be diagnosed with schizophrenia. And so we know the environment played a part, but that genetic part was very significant. And the concordance rate was 50%, which is amazing. And so with schizophrenia, bipolar disorder, and autism spectrum disorder, we do know that there's a strong genetic base. And oftentimes, even with ASD, you'll find that there are multiple children in a family who have been diagnosed with ASD. So we know there's a genetic component, and there's more work to be done on delineating all the details of that. Environmental influences, I think, is so important that we also talk about that. We know that housing, educational background, whether there are food deserts or easy access to food and healthy food, if there are high crime areas in your neighborhood, if there's a history of abuse, whether that's physical, sexual abuse, neglect. We know that hazards in the environment and illness and disease are all environmental factors that play a part in the development of mental illness. And as we said, there's no one specific factor that determines whether or not someone will develop a mental illness. But the genetics and the environmental influences are significant, and we know they both play a significant part. There are other contributing factors to mental illness other than just the things that we mentioned, but environmental exposures prior to birth, that would include exposure to cigarette smoke, that could include exposure to alcohol or illicit drugs, pain medications. And we really try to inform pregnant moms about the dangers of certain types of chemicals and exposures. And the information and studies are profound about cigarette smoke and how it affects the blood flow to an unborn child. All of these types of exposures we know are very relevant. And also, there's some recent evidence that certainly is suggestive of marijuana exposure in utero being connected to autism spectrum disorder. Traumatic brain injury, other medical conditions are associated with depression and mental health conditions. Substance use disorders can be associated with dementia and a host of other types of mental health conditions. And there's a lot of talk now about isolation and how it is a precipitant to depression, especially in the elderly, which we'll talk about a little bit later in some future slides as well. Chronic stress. I think we are probably all aware of the impact chronic stress can have not only on our mental health, but our physical health as well. We do know that stress can actually change brain chemistry and structure. And we've seen this on PET scans, especially related to children who've experienced a lot of stress related to abuse, especially chronic abuse. And what happens is there is inflammation throughout the body when there's chronic flight or fight, which is a response to stress. It increases certain hormones and chemicals in our bodies that can be toxic and throw off our homeostasis. And so chronic stress can lower your body's ability to fight against disease, and it can certainly make you more vulnerable to a host of medical problems, diabetes, viral and bacterial infections. Certain types of cancers have been linked to stress. And we know chronic stress can certainly exacerbate mental illness. There's some new research that connects stress to heart disease, and it's a very interesting pattern in terms of how that develops. But for this conversation today, we won't go into any detail about chronic stress and cardiac disease. That'll be another talk. I have to talk about COVID-19. COVID-19 did not cause the mental health crisis. I just want to make that clear, but COVID-19 certainly did exacerbate an already pre-existing mental health crisis. And for all the reasons that you see here on the slide, the morbidity that was associated with COVID-19, the deaths that were associated, the economic downfall, unemployment issues, housing loss, the isolation and separation that we mentioned earlier, the fear and anxiety, anticipation of catastrophic illness and death, and the school closures, which had a significant impact on our children, which is partly why we're seeing the rates of anxiety and depression that we are seeing in our children, as well as a high suicide rate. So all of this has come together, the perfect storm, to create a mental health crisis. So let's talk about some statistics, because I think a lot of these statistics are very startling and it's important to highlight. People with mental illness are often victims of crimes. About 1 in 5 people in this country suffer from a serious mental illness, and that estimate is about 58 million people. Half of the mentally ill in this country are untreated, and it's estimated that 50% of those suffering from mental illness are uninsured, which makes it very unlikely that they're seeking any care or treatment. The suicide rate in this country increased every year from 1999 until 2018, every year, so almost 2 decades. We have seen a decline from 2019 to the present day, a slight decline, but progress is progress. The second leading cause of death in 10 to 34-year-olds is suicide. The first is accidents and injuries. And it's estimated that about 1/3 of our homeless population is suffering from a mental illness. More statistics. We've seen a 63% increase in overdose deaths since 2019. Up to 20% of our prison population suffers from a mental illness. And this is a startling one. The suicide rate is 2 times that of the homicide rate. So you're twice as likely to die of suicide than a homicide. Over the last 10 years, the suicide rate has surpassed fatal car accidents. And last year in Virginia, we lost close to 50,000 lives to suicide. And I want to point this out because there's an incorrect association that people with mental illness are violent. People with mental illness statistically are no more violent than the rest of the population. Another startling fact, every single locality in Virginia is now federally designated mental health professional shortage area, which means we do not have enough mental health professionals to provide the care that is needed in any of our communities in the state of Virginia. Critical shortage. But what is Virginia doing? Virginia is actually doing a lot, and I just highlighted here some of the things. Governor Youngkin has a Right Help Right Now youth mental health strategy, and it is intended to overhaul the state's mental health care system by expanding crisis services and tackling substance abuse challenges. And our Attorney General, Mayorkas, filed suit against Meta for harming youth mental health. He filed a lawsuit alleging that the company knowingly deployed harmful features in Instagram and other social media platforms that are purposefully addictive for children and teens. And then we have Jen Kiggins, who was personally a tremendous help to me. One of the roadblocks to getting mental health professionals trained was a step that nurse practitioners have to take after their formal academic training. They have to spend so much time practicing in collaboration with a psychiatrist, but there are so few psychiatrists that the nurse practitioners were backlogged and were waiting for opportunities to collaborate with psychiatrists. So a couple of years ago, I met with Jen Kiggins and I told her that it would be very helpful in minimizing the mental health shortage if the number of nurse practitioners that a psychiatrist could collaborate with could be increased from 6 to 10. A few months later, get a call from Jen Kiggins, it went through. So that has been a tremendous help to psychiatrists who are willing to collaborate with nurse practitioners to help them along their path to be good and qualified, competent mental health providers. So thank you, Jen, forever indebted to you. And EMS of Virginia provides community stabilization opportunities, and that minimizes the need for hospitalization oftentimes. And we now have a 988 hotline, very similar to 911, but you can dial 988 if you have a mental health crisis, and you can receive help through that hotline. I have to talk about our aging population because this is another important issue for us to be aware of. With the baby boomers aging, we're going to be treating and evaluating older people. And I just wanted to highlight for you some of the statistics and issues that we're seeing when we're dealing with the aging population. So as we age, we're more likely to experience the loss of loved ones. We're more likely to be alone and isolated. As we age, we're more likely to have health concerns and serious illnesses, and oftentimes cognitive decline, and along with aging, often physical decline. So let's talk briefly about aging statistics. Women 50 and older report depression more than their male counterparts. We don't know if they have depression more or if they are just more likely to seek treatment. Mental illness is not a normal part of aging, so it's not what we expect as people age. People 85 years and older have the highest suicide rate, 85 and older. So you have to really keep an eye on the elderly population. And that's followed closely by those aged 75 to 84. So, if you have elderly loved ones, please pay close attention to them and be aware of any signs of depression or mental illness that may develop. 5% to 7% of the population over age 60 suffers from depression and or dementia. With the aging population, we're seeing more and more dementia. 4% of the adults over 60 suffer from anxiety, and nearly 1 million adults 65 and older live with a substance use disorder. Treatment options. I put the first two at the top because those are the standard methods of treatment for mental illness: individual therapy, group therapy, and medication management. Transcranial magnetic stimulation, ECT, which is electroconvulsive therapy, brain stimulation, which is still being tested, and there is evidence and studies that do support that acupuncture may be helpful in treating some types of mental illness. Who are the credentialed professionals who are credentialed to diagnose and treat mental health conditions? Psychiatrists, who are medical doctors who have completed 4 years of college, 4 years of medical school, and 3 or 4 years of a psychiatry residency training. And I say 3 or 4 because one of those years may be what we call a transitional year that's done in primary care with 3 years of psychiatric training. We have psychologists who are also equipped to do testing to help with diagnosing. We have nurse practitioners who are also prescribers, physician assistants who are prescribers. We have licensed clinical social workers and licensed professional counselors, all who are qualified to diagnose and treat mental health conditions. The only people at this point who are able to prescribe medications are psychiatrists, nurse practitioners, and physician's assistants. Good health is our best ammunition against mental health conditions and physical health conditions. And what does that mean? It means eating a healthy diet, getting regular exercise, maintaining a healthy weight, getting adequate amounts of sleep, having regular visits to your medical provider, and those healthy coping skills that we talked about earlier really should be utilized. So let's get started. Let's start doing those things that we know will be helpful in mitigating our risk of mental and physical conditions. How can you help? All of us can play a part in addressing mental health in our communities. We can help by destigmatizing mental illness, by raising awareness, by supporting mental health education in schools. We can encourage and support those who suffer from or who appear to suffer from mental illness to seek professional help. We can identify mental health professionals who are willing to provide educational opportunities and forums such as this in your community. And we can make our own physical and mental health a priority and set examples for others to do the same. Post-test, true or false? Let's just close this by answering some questions that hopefully are easy to answer now that we have gone through the slide deck. Mental illness is not a real illness, true or false? The answer is false. Mental illness is a real illness. There is a genetic predisposition for developing mental illness, true or false? True. We know that genetics do play a part in the development of mental illness. People with mental illness are weak-minded and need to be stronger. Well, we know that there's a genetic component and we know that there's an environmental component. So no, they're not weak-minded. They're people who have an illness. We need to be more compassionate. Psychiatry is not a real medical condition or medical specialty. Well, as we said, psychiatrists are actually trained as medical doctors, and psychiatry is a real medical specialty. Antidepressants are not really effective in treating clinical depression. We talked briefly about medication management, but antidepressants are generally effective to varying degrees in treating clinical depression. Psychiatric drugs are dangerous and have serious side effects. Psychiatric drugs have been approved by the FDA, and their safety has also been thoroughly studied prior to the FDA approving them for official release. Most of them do not have significant side effects for most people, and so they are not deemed to be dangerous, and for the most part, for most people, do not have serious side effects. People with mental illness tend to be violent. We did have a slide that addressed that. People with mental illness are no more violent than the regular population. Suicidal deaths are on the rise, and this one might be tricky. That's actually false. From 2019 until the present, suicidal deaths have actually decreased. They were on the rise for 2 decades prior to 2018. We are not facing a mental health crisis at this time. That is false. We are facing a serious mental health crisis. In summary, we are in a state of crisis when it comes to mental health. COVID-19 and environmental factors have exacerbated our present mental health status. It is important that we take our bodies and make our overall health a priority. This is a dire but not hopeless situation, and we do have the power to turn it around if we do the right things. Yay, a picture of good mental health. I want to thank you for your time this evening, and I'm going to turn this back over to Lisa Carey and Ed Gonzalez. Thank you so much for your attention this evening.
Thank you very much, Dr. King. Just a reminder to families, we will answer all questions at the conclusion of the webinar. Please use the Q&A feature at the bottom of the screen for any questions. At this time, I'd like to welcome our next panelist, Mr. Ed Gonzalez. Edwin Ed Gonzalez has been with Chesapeake Integrated Behavioral Health, which we call CIBH, since 2015. He started as a Developmental Disabilities Programs Director. The position evolved to be the Care Coordination Programs Director in 2017. In 2022, he was named the Executive Director of CIBH. He has a vast experience in the field of behavioral health and developmental disabilities for over 35 years. Prior to working with the City of Chesapeake, he worked for the Developmental of Behavioral Health and Developmental Services for almost 17 years in a variety of capacities, with the last 8 in the Office of Licensing. Born and raised in Brooklyn, New York, he is a diehard New York Yankee fan. He is proud to call the City of Chesapeake home for 29 years. At this time, I'd like to welcome Mr. Gonzalez.
Thank you, Lisa. I appreciate it. First, I want to thank Dr. King for her expertise, her insight, and for the great overview regarding mental health. And I just want to put a plug also to thank Lisa, Ms. Tawana Fortune, and the rest of the team for allowing us and giving us the opportunity to share and be part of educating families and our youth related to this important subject. What is Chesapeake Integrated Behavioral Health Care, and what do we provide? The first thing is, we need to understand what behavioral health is, and clearly it is a priority area, and it encompasses it encompasses physical health, mental health, and substance use. And you have to take it as a whole. So realistically, one may have, there's some individuals that may have a mental health disorder. There's some folks that may have a substance use disorder. But then there's also individuals that deal with physical, and Dr. King had touched on, certain ailments that folks may have, including diabetes, heart health issues, and so forth. So CIBH, which obviously I lead, and I'm very proud and fortunate to do so to the community. Part of what we do is offer services to our community. And how do you do that? One of the first things that we tell families and individuals is we have a same-day access clinic, meaning that it is an integral part of what we do. Is the point of entry of services. It provides you with the opportunity to discuss, basically review your background, your history, that ultimately leads to a diagnostic impression that identifies then the different services that you may be able to access, and identify also, helps the individual and the family identify what are the needs and how basically we can guide you to those resources that are so important in terms of addressing these needs. Some of the services that we provide is outpatient counseling, and that's done by our licensed clinicians, both for mental health and substance use disorders. We provide substance use groups, psychiatric services for medication management, and case management. And that encompasses mental health, substance use, intellectual and developmental disabilities, and not to discount that. Next slide. So, so what happens when you go through this same day access piece? One is your triage, and basically we want to make sure that if the need that's been identified, is it something that we could take care of, or is it something that we could link the individual and the family to a community resource? And that's okay. Ultimately, a lot of times families just don't know where to go and how to access resources that are basically embedded in our community. So we basically provide that resource to basically say, hey, if it's something that we can't provide, then we're going to link you to a community resource, and we'll have those conversations with the individual as well as the family. If someone's in crisis, then we'll do a consult and we'll coordinate care so that basically we could address that need through our emergency services department. There's a registration process that we go through. We collect demographic information, we collect insurance, payment information, and we also review the ability to pay. Okay, especially in these hard times, we have a fee scale that if someone doesn't have insurance, that basically we go work with the family and that person. We create an individual chart to an electronic health record. We collect all the information that's necessary, and then we do an intake. Next slide. Can you go back one? Thank you. So the intake is, so you get hooked up with a licensed clinician, and the licensed clinician does what we call as a master intake assessment. And basically it's a psychosocial assessment, which means that it covers, okay, what are the concerns? What are the needs that have been, that someone has had? They might be upset, that they're depressed. All those different criteria that Dr. King talked about. These are questions that we ask the person, the family, to help us gather as much information regarding the person, so that way we could do a good review of what those needs are, to properly then make those recommendations as to how we can assist. If a person is suicidal, we'll discuss the individuals, if there's any medical concerns, their mental health history, if there's any substance use concerns, family social summaries, if there's issues with regards to trauma, any legal history, issues related to daily living skills, and if a risk assessment. If someone is basically saying they're going to harm themselves, we want to make sure that we develop a safety plan for that person. Okay, so as we want to assure that when you leave our office, that hey, you're going to be safe, and that we address those needs in the immediate to ensure that basically you are taken care of. So what are some of the programs that we offer here at CIVH? And we're located at 224 Great Bridge Boulevard, which realistically, I would say maybe we're like 2 miles, 2.5 miles away from the Great Bridge Thurway there, right in the intersection of Battlefield and Graybridge. We're just down the road. We're up the street from Oscar Smith High School. We may offer our office-based addiction treatment, which are our OBOT program, for those individuals that have a opioid dependency. Emergency services, which is real critical. Someone's having a hard time. We have 24-hour, 7 days a week, 365 availability. We have clinicians available to assist an individual that is in crisis. We do have individuals enrolled in our drug court. We have behavioral health docket, part of our forensic services. We have what we call an ACT-team, which is an assertive community treatment. And this is a service that wraps services around the person that really has a serious mental illness, and to ensure that basically they have an opportunity to be part of the community and function in the community. So in that particular services, we have a nurse, we have a case management services. We go every day out to ensure that the individual is taking their meds, their medication that's prescribed, and so forth. Next slide. An integral service that we provide is prevention services, which does a tremendous amount of outreach and training to the community. One thing that we do is mental health first aid, which is a training that we provide because people many times don't understand, how to relate, how to interact with someone who has a mental illness, how to basically communicate, how to diffuse, how to redirect someone who just doesn't know. Okay, so we provide that training free of cost to the community. We do Revive training, which is it's a half-hour training with by the time you finish this training in a half hour, we provide naloxone, which is an important assistance if someone overdoses. Okay, so those are some examples of some of the trainings that we provide. We offer some of these trainings within the schools, and then a lot of city entities, private groups, church groups, and so forth. Peer recovery services, one of the best utilization is having individuals with lived experience, someone that you could talk to that has experience and has basically gone through those crises, that have a mental illness, but that they've run and have exceptional lives. Individuals who have lived experience because they've experienced substance use. So imagine having a discussion with someone who's been there, who knows the struggles, who knows what families go through to address those needs. Psychosocial rehab is a community day program for individuals who have a mental illness that are offered to our adults. We have intellectual disability services where we provide case management services, and also we provide services to those individuals who may have an intellectual disability, a developmental disability, and when linked families. And I always say that it's important that families within the school system, if you have a loved one who has a developmental disability, reach out so we could provide you with information, because many times what families struggle with is what happens after school. Okay, my son and daughter's 18, 22 years old, depending in terms of that they're in special education. What happens after that? And we provide that guidance and that education with regard to how to navigate the next steps. Infant Toddler Connection of Chesapeake, for those families who have babies till 3 years old that are not meeting those developmental milestones. We wrap services around the child to help and assist them reach those developmental milestones now. And I'm going to throw a plug in there. We provide one of the best programs across the whole Commonwealth. We are known for our Infant Toddler Connection Chesapeake program, that early intervention services. We link up with pediatricians throughout the city of Chesapeake and educate them, and we get a lot of referrals through that process. Next slide. So part of what we do is with Chesapeake Thrives Initiative, which is a city developed initiative with regards to how we can basically get the information out. And what we say is to strengthen, expand, diversify behavioral health prevention-oriented programming. It sounds complicated, but it really is not. So where we've been. Next slide. Our prevention team provides, like I had indicated, a multitude of trainings and presentations throughout the city, not only to community members, but it's also to providers and city employees. We host a number of tables at events. We are part of and we lead the Chesapeake Prevention and Wellness Coalition, which that's what the CWPC initials stand for. Or we're involved in Chesapeake Thrives initiatives. And if you don't know what the Chesapeake Thrives initiative really is, you can always go to the Department of Human Services website, Google Chesapeake Thrives, and it'll show what the city is trying to do in terms of educating the community related to a number of different initiatives throughout the city. We distribute RAC cards. There's always marketing and awareness strategies. We have flyers, billboards with regards to really pushing initiatives to address the needs of the community. We talked about a little bit about the peer services. We filmed a Recovery Life series that's available that discusses behavioral health and interventions and the treatment efforts to decrease the stigma. And this is part of, you heard a lot of information from Dr. King, and there's a lot of stigma related to behavioral health on the conditions and what people think. And this is ultimately what we're trying to work through, because just because you have a mental health a concern doesn't necessarily mean that life is over, right? This is something that you live with. You basically address it and you move on. People have normal lives, so it doesn't mean that there's there's always this stigma of surrounding someone who may have a mental illness or a substance use issue. It doesn't mean how we've done things in the past is what we're doing now. Okay, next slide. So where are we going? Our prevention team has been taking steps to get more involved in the public school system with the youth and faith-based communities. We're partnering with a digital platform called Healthier 757 that will allow free online access to a wide variety of informational resources targeting prevention and treatment for behavioral health. We were recently awarded a grant for a mobile harm reduction unit that will be promoting community awareness, prevention for mental health, substance use, as well as wellness resources that are available. We were very fortunate to receive a grant from the Department of Behavioral Health and Developmental Services. We have a mobile unit that we're trying to get so that we'll be out in the community providing those that information, but it's also and hopefully we're able to do that is provide those services in the community. Okay, there's always access issues regarding transportation. Wouldn't it be great if you know that there is a mobile unit that you can receive some services from? So ultimately, that's a vision that we have that we're basically based on the grant that we're able to basically meet. So another priority area is to strengthen, expand, and diversify our behavioral health and intervention services. We have a number of opportunities. Next slide, please. Where if someone has a difficulty getting here, that we offer. I'm sorry. I'm here just going through make sure. So I skipped along in the slides. My apologies. We're part of a group. We're a coalition that our team reaches out to individuals in the community. We work with local providers on services that ultimately, let's say we don't have the ability to provide a particular services, that we'll link families to those resources in the community. We work with community members to come like for instance, so if we have identified a provider that, hey, if it's something that we don't provide, that we could link up with a community provider to help us and assist that family. We have our prevention team utilizes multiple media platforms. We also work with Chesapeake's public communications that really assists us in terms of developing information to get out to the community. I talked a little bit about the mobile harm reduction unit, and that we'll be working with the HealthyF 757 digital platform. And what this will do is that increases our collaboration, making sure that we're basically have an opportunity to provide those resources and make the community aware of those resources that are available to help decrease the stigma associated with behavioral health. We work with the Virginia Department of Health and Healthy Chesapeake in terms of partnering with them related initiatives about harm reduction. Harm reduction realistically is, hey, knowing that as someone who may have a substance use, what we can do to educate to assure that they basically are receiving and have an opportunity to receive treatment services. The harm reduction unit that we're planning will be peer run. And ultimately, this is where you want to make sure that someone who has lived experience could really engage with folks that basically might be having an issue. And ultimately, the openness and the ability to communicate is real critical in terms of getting the help that folks need. Next slide. One thing I was about to start is that, the difficulty of getting here, we offer bus passes, okay, interpreter services, and this is really big, especially for our Latino community. If we know that someone doesn't understand, we basically link up with an interpreter service so that we assure that the individual is able to explain in their own language what is going on. We talked about the sliding fee scale of the ability if folks don't have the ability to pay, that hey, what can we do to assist? And we're not going to turn anyone away. One thing, especially in today, and something that we learned with the pandemic is the opportunity that we provide telehealth services, both, either you want to see someone in person or we offer that virtual opportunity so that you can meet with your clinician online. Okay. Excuse me. And we also linked up with the Department of Human Services that if you have an opportunity that we could also we have a worker that assists families in terms of filling out a Medicaid application if you qualify for that. We expanded our hours regarding same-day access clinic and outpatient services. We do offer some evening hours for those services. We also staff and our partners at our We Care Resource Center several days a week. And this is where individuals who may be homeless, families who are homeless, and that are seeking resources, that we have a clinician that is there a couple of days a week to assist in that process. And another plug for our prevention team, that they're always hosting resource tables at a number of events, and ultimately is to promote awareness of who we are and what we do and where to receive those services. So where are we going? I talked about the mobile harm reduction unit that's coming. We're opening a 24-hour, 23-hour crisis receiving center, which is right next door to where we are at 216 Great Bridge Boulevard. Initially, we're going to be operating Monday through Friday. We are very, fingers crossed, toes crossed, that hopefully we're able to open sometime in March. And those are for individuals who are in crisis. Typically what happens is someone goes in crisis, an individual goes to an emergency room, and you linger in the emergency room, you require a big emergency uh, services bill from the hospital, and then you're like, okay, what services did I receive? Our crisis receiving center will work with the individual, hopefully get them stable enough so they can go back home. Okay, we'll wrap services around that person, and what's important is the aftercare. I'm in crisis. I stabilize you, but but tomorrow I'm going to ensure, and I'm saying this now, I'm going to ensure that one of our staff, one of our clinicians, is going to reach out to you and the family to check in to see how you're doing. Are you going to follow up with regards to going to the doctor? Many times, well, an individual that goes into crisis because they stop taking meds or they ran out of meds, and then they go into a crisis, or something happens in their life that to the point where, hey, I want to hurt myself. And it's a unfortunate situation, but these things happen. So our crisis receiving center is going to work with the individual. Now, if and granted, right now it's going to be geared towards adults, but it doesn't necessarily mean. And here we're talking about youth, right? People in school. It doesn't mean that those services are not available to you in the community now. Okay, we do have regional collaboration with Western Tower Community Service, that if someone's in crisis, they will go to you. Okay, and Dr. King talked about 988. 988 is an integral part of our behavioral health system as of now. So if someone's in crisis, you can call 988. And mind you, the regional relationship that we have, a licensed clinician or a clinician will reach out to you, and they will provide those wraparound services for your loved one, and basically navigate that process with regards to how we can stabilize that person. And if the individual needs a higher level of support, what can we do to assure that person's taken care of? And also for our office-based treatment program, which we're trying to grow, that is geared towards individuals who have substance use, and the wrapping of services for someone to receive Suboxone, which is a derivative to assist an individual who has a form of addiction related to a substance use concern that they have. Next slide. And I thank you. And I appreciate the opportunity. And by all means, please, if you have any question, and I know we're going to open up for question and answers for the short period of time that we have left. But if there's anything that I could do, my information is set for you. And thank you very much for the opportunity. I'll kick it back to Lisa. Thank you.
Thank you very much, Mr. Gonzalez, for your wealth of knowledge. At this time, I think we have a couple questions, and so I'll ask Tawana Fortune, if you don't mind sharing those questions with us.
Yeah, so my first question is for Dr. Pat King. So, Dr. King, you shared with us a host of different types of disorders. You talked about anxiety and depression, autism spectrum disorder, ADHD, post traumatic stress disorder. But I'm wondering if parents want to know, can you have more than one disorder or diagnostic impression at one time? Can you have more than one?
Yes. And that's a great question. Thank you. Yes. It is very common to see what we call comorbid conditions, and that means more than one mental health diagnosis present at the same time. There's some disorders that run commonly together. For example, autism spectrum disorder and ADHD very commonly see the two. Major depression and anxiety. A large percentage of people who suffer from depression also have an anxiety component. So yes, there's not a limit to the number of mental health conditions that you can be diagnosed with, and very oftentimes there are comorbidities.
All right, and I have another question for you. So you talked about anxiety disorders and separation anxiety. And sometimes we have 5-year-olds that start school and they're very clingy to their parents. But then you might have a 6th grade student who's 12 years old and having difficulty going to school. Is there some developmental milestones that are just appropriate for kids to have separation, as opposed to someone that might be older in a middle school setting?
Right, right. And another great question. And expect a 4 or 5-year-old to be a little more reluctant to separate from a parent and to go into a classroom with people who may be unfamiliar. and an unfamiliar authority figure, especially early on in the course of maybe a school year or early in the course of kindergarten, first grade, whatever the situation may be. But when you look at someone who's maybe 12 years old, that's a different issue because at that point they've been through years of school and separating. And so you wouldn't expect to see that same level of anxiety that you would see in a 4 or 5 year old. So if there is a significant issue with separating at that age, I would definitely have an assessment done and would recommend that a professional make an evaluation and assessment.
All right, thank you. So, Mr. Gonzalez, I have a question for you. So, I'm a parent and I feel like my child is having some emotional difficulties, and I'm starting to see some changes, right? I'm starting to see them sleep more. They're hanging out with some different types of friends. I'm noticing that when they come home, there has a smell of marijuana in their clothes. Is that something that CIBH could help me with my child?
Absolutely. Absolutely. This is where, you know, really identifying those resources available to the family in the community. It won't hurt my feelings if someone doesn't come to our shop. Right. My thing is important that we really address that need of that child. So we could provide those resources or that guidance to those resources in the community, especially if if someone doesn't want to come to CIVH. I think ultimately is to address those needs that a family may have. We have a process. You can go through same day access and contact our team and go through that process, go through that assessment, and that way they can link you to, okay, fine, if there's a service that we could provide, and if, again, like I said, if we can't provide the service, we're going to help that family seek out those resources in the community.
We do have some questions in the chat box. Are there any plans to develop a coalition between public and private providers of mental health care in Chesapeake? And I'm not sure which one of you all could probably answer that, perhaps both of you all.
I'm sorry, Dr. K. There is right now, especially with 988, there's a number of private providers that are going to be doing like what they call crisis stabilization. And that is coordinated through a regional, what they call a regional hub. There's several CSVs within our Tidewater region, okay, that's really considered Region 5. And we work collaboratively, okay, as sister agencies with regards to, let's say, this whole crisis continuum that the governor really is pushing for under his initiative of Right Help Right Now that Dr. King talked about. So, in terms of in Chesapeake per se, there is, that I'm aware of, there's not this collaborative, like this private providers with us. But I know in past, they used to be not a coalition, but there used to be a gathering of private providers with the CSBs many moons ago. And it could be something that, hey, if there is interest, I think at the end, we're all here together to provide a need for our community. And if there is interest, then, I don't have a problem in terms of exploring that opportunity.
Wonderful. I do have another question for you, Mr. Gonzalez. It says, is the 23-hour crisis center different from the CIT center at Chesapeake Regional Hospital?
Yes. Okay. So what our crisis receiving center, which is our CIT, is going to be co-located in this new site. So initially we're going to be probably in both places. But eventually, when we go full operation, we say 23 hours, but realistically it's 24 hours. Our CIT program will be at our crisis receiving center. So we're going to co-locate there.
All right, thank you. Well, Ms. Carey, those are the questions that have been posed in our Q&A. I'm not sure if you want to close out.
Yes, thank you so much, Ms. Fortune. I would like to thank Dr. King and Mr. Gonzalez for sharing their information with our families. Remember, if you or someone you know is suffering from a mental condition and in need of help right away, please don't forget to text 988. You can also visit 988lifeline.org for more assistance. Should you have any questions about tonight's webinar or need additional resources or need to figure out a way to contact Mr. Gonzalez at CIBH or Dr. King or Miss Fortune with Chesapeake Public Schools, please feel free to reach out to face@cpschools.com and we will be more than happy to connect you to the right resource. Thank you again for joining us. And remember, families and communities work better together. Have a great evening.